You can. We're new.
We're giving Shayna a pass for this.
Yeah.
Are we ready? Do we need to go? What time? Okay. Hello, everyone. Welcome to Breakfast at Sky, the first after the summer. So good job turning up and keeping it in your schedule. And I'd like to welcome today first a new person. As people know, Jessie Shea headed off to Ireland, and last I heard she landed and was safe and sound. So I didn't want to be too maternal and ask too many more questions, so I just know she's there. So I'd like to welcome Shayna Pierce. Shayna is our new research coordinator at RCC, and she'll be up here soon, but we gave her a pass on this first one. So welcome, Shayna. And welcome to Chelsea Korstrom and Megan Guglich. I would say your name, Guglich. I didn't think. From our Prosthetics and Orthotics Department. They are going to present on services this morning, as well as any new initiatives, and then we'll take questions at the end. Thanks.
Hey, good morning, everybody. Thanks for coming. Can you hear me? Cool. So yeah, I'm Chelsea, this is Megan, and we're gonna just walk through things going on in the Prosthetics and Orthotics Department. Make it go. There we go. I'm new.
So just to let you guys know kind of how we're going to do things this morning, first we're going to explain to you a little bit of what we do and give you some definitions about prosthetics and orthotics. We'll introduce you to our team and talk a little bit about the education requirements if you're going to become a clinician or a technician in the P&O field. Then we'll walk you through our treatment process, what we do when we're seeing kids here. Talk about the way our program is funded and how you can refer patients to us. And then just talk quickly about a couple of special projects we have going on in our department, and then answer any questions you guys have. What did you do? So in our department, the main thing that we do is provide assessment, fabrication, fitting, and follow-up to any kids who come to the center who need any prosthetic or orthotic care. Most importantly, what we do is assist our clients in reaching their full potential by providing a family-centered model of care. Still me. So for anyone who doesn't know, a prosthesis is also called an artificial limb, prosthetic arm, prosthetic leg. It's a device that replaces a missing limb or part of a limb. So in our department, we see kids who may have been born with congenital limb loss or limb difference, or who may have lost their limbs through injury or some type of illness. And we see kids who are missing their limbs anywhere from the shoulder distally towards missing a finger, or missing a limb from the hip all the way down to maybe just missing a toe.
Okay, and an orthosis is defined as any externally applied support for a joint. So the goals can be any of the following or a combination of them. So we're trying to achieve or maintain proper joint alignment. We're trying to stabilize injured joints to allow for healing. We're trying to prevent or slow the development of joint contractures. We're assisting with function, and in some cases, we're relieving pain. So in orthotics, majority of what we do is lower extremity. So we're doing AFOs, SMOs, foot orthotics, knee braces, some KFOs. We do some hip abduction orthoses, and we're doing spinal orthoses. We do a lot of neuromuscular scoliosis, some adolescent idiopathic scoliosis. For upper extremity, we're doing, again, from shoulder, elbows, wrist, hand orthoses, and we also do some helmets. In the orthotics department, we see about 150 to 200 visits per month. And within those visits, we're dispensing about 120 devices a month. So we're pretty busy. And these are the wonderful people in our department. So we're pretty small. So starting at the top, we've got 3 certified orthotists, myself, Jackie, and Ed. And we have our certified prosthetist, Megan. And then for technicians, we have 3 registered technicians. So we have Kate, who's registered in prosthetics and soon to be in orthotics as well. Randy is registered in both prosthetics and orthotics, and Doug is registered in orthotics. And then Alicia is an orthotic technical intern working with us. And then we have Barb is our director, Matt's our manager, Stephanie is our admin assistant, and Kim is our clinic assistant. So if you're at all interested in becoming a certified clinician or a registered technician, this is what you'd have to do. So to be a clinician, you need a 4-year undergraduate degree, and then you need a 2-year postgraduate diploma. And we study both prosthetics and orthotics in school. And then you choose one discipline to do your 2-year residency in. You write your written and practical national exams. Once you pass those, you're certified. And if you want to become dual certified, you then have to do another residency and another set of exams. So yeah. Primary responsibilities of clinicians were assessing patients, designing, modifying, and fitting the devices. We're managing the treatment process. We're working closely with physicians and other healthcare professionals. We're doing practice management, patient advocacy, and evidence-based practice. So most clinicians now are getting their master's degrees concurrently through school and then finishing them in their residencies. And there's a big push in P&O to have a master's level education program to keep us on par with physiotherapy and other professions. And to be a technician, you need a 2-year college diploma, and that's again in both prosthetics and orthotics. You then choose one discipline to do your 2-year internship, or you can do a 4-year internship if you don't have the diploma. Do your written, practical, and national exams. And again, if you want to dual certify, you're doing another internship, another set of exams. And primary responsibilities of technicians, they're designing and fabricating our devices. They're doing materials and inventory management. They're doing ongoing repairs and adjustments, and always working on device quality improvement. Yeah. So this is kind of what our treatment process looks like. It's very cyclical, but it's always starting with a client assessment, and then we're going through some form of shape capture, designing a device, modifying a positive model, fabricating the device, fitting and optimizing the device, and then performing follow-up repairs and adjustments. And then with the kids here, typically we're starting this wheel again within 6 months to a year due to growth. We're doing another assessment. So at our initial assessment appointment, we're meeting with the kid and the families, and we're reviewing, relevant medical history. We're very lucky here to be able to consult other health professional chart notes. We're looking at your referral letters, prescriptions. We're discussing past devices that the kid might have had, what went well, what didn't. We're talking about current therapies they're working on. Then we'll do our strength, range of motion, and gait assessment. There's a lot of discussion about child and family goals because we want to make sure that we're actually doing what the kid wants to do. And then we're booking the fitting appointment if possible. And then for shape capture, typically a cast is taken of the limb, either with fiberglass or plaster. We're taking measurements, and we're casting that limb in as ideal a position as we can get. Sometimes that can be pretty interesting. And in some cases, the limb segment can actually be directly scanned with our 3D scanner. We don't do it a lot, but there is some application for some spinal orthoses and I think in prosthetics as well. So the scanner that we use, it's the Vorum CAD system. So you can see here they're scanning directly the torso of a person for a spinal orthosis. A lot of our kids can't really stand that still enough to get a scan, so we're either doing a supine and prone scan or we're taking a cast. And then we're scanning the outside of the cast. So then in the middle picture, we have our digital positive model, and this is where we do our modifications on the computer. And then to create our 3D positive model, we send it to our carver. It's on the right-hand side there. We're very lucky to have our own carver in-house. We're one of the only facilities in Canada that has that. And this starts with a big foam block, and it carves it down into our positive model and gets it ready for fabrication.
So after we've done our assessment and determined what the child and family's goals are and what their current abilities are, then we have to design a device for them. Some of the things we want to take into consider are the characteristics of their limb, how long it is, the consistency of the tissue, their sensitivity, things like that. We want to keep in mind that they are small and have limited strength compared to adults, so we want to make sure that the devices we're making are really light and easy for them to use. we need to think about the fact that they're constantly growing and that their limbs are changing shape. So we do a lot of adding pads and liners that we can remove as they grow to make the device last as long as possible. We want to remember that kids are very active and take into account any of the special activities that they're doing and make sure the device is going to be strong enough to stand up to those forces. One of the challenges we deal with a lot is that there's limited room for componentry, especially in prosthetics. So we're making sure we're ordering like pediatric componentry, stuff that's going to specifically fit in the device. And then we use like some commercially available terminal devices or adapters. Sometimes we have to design our own. It's really individual to every case. One of the specific things that we do a lot of here are recreational prostheses, which have even more design considerations. Again, we want to make sure that they're lightweight and strong for the specific activity that the child is trying to do and accommodate for growth and changes in length. But we also want to make sure that it's really easy for them to use, especially if it's a new activity that they're trying to learn and use their device for. We want to make sure that they're retaining as much sensory feedback as possible so that they can learn easier how to do the activity. There might be a specific alignment for that device that's different from a typical prosthesis, like a limb might need to be made shorter or with a terminal device at a different angle. And for all of our kids, we want to make sure that everything's custom designed specifically for them so that it meets the function that they need, but also that it looks the way that they want it to, so that they'll keep using it and think it's a fun device to use.
So once our device is designed, we're then going to be modifying our positive model. So we're either doing this in plasters in the top image, or we're doing it digitally using our Vorum system. Either way, the goals are the same. We're trying to relieve pressure in sensitive areas, so over bony prominences, and we're trying to increase pressure in load tolerant areas, and all the while trying to correct or find the ideal position in our alignment for that limb. And we're defining the trim lines of our device as well. And then the positive model is then prepared for fabrication. So we're either smoothing the plaster model or, as we talked about, grinding or the foam block into the positive model to be fabricated. So for most of orthotics and for some prosthetic diagnostic sockets, we're using molded thermoplastic as our fabrication technique. So the positive model is hooked up to our vacuum center, and the plastic's heated in the oven until it's pliable. It's draped over the cast, and vacuum's applied to mold the plastic into the shape of the cast. That's then cooled, and once it's fully set up, it's getting trimmed, finalized, straps and everything will be added, and it'll be ready for the fitting appointment. We have lots of different transfer paper patterns available to kids. You can see the jets have been very popular, so it's kind of nice to be able to customize it for all of the kids.
In prosthetics, we use a fabrication technique called lamination, where we lay layers of material like fiberglass, carbon fiber, in some cases things like Kevlar, over top of the cast and put all of those under vacuum. And then we run a liquid resin through all of the material under vacuum so that it cures into the shape of that cast. Because we do it with that process with layering materials, families are able to bring in pretty much any material that they want for the outside pattern of the device. So for example, in the top corner, that's actually a pair of pajamas, Paw Patrol pajamas for a swim leg. But we can also even print pictures off the internet onto like a fabric paper, iron it onto a t-shirt and use that. So it's pretty much infinitely customizable with this technique.
So most of what we do in our department is custom made in-house, but we do have some areas where we're doing off-the-shelf or custom from measurement devices. So we're doing some spinal orthoses custom to measurement. We'll do Benic upper and lower extremity orthoses, carbon fiber AFOs, helmets, some standing frames. But all of these will still require the custom fit and adjustments from an orthotist. And
in prosthetics, we also do some centrally fabricated devices, typically for cosmetic partial hands and partial feet. So they get really detailed, lifelike looking devices that way. One of the other processes we're starting to use a lot of is 3D printing, especially when we're trying to make custom devices when there isn't a commercially available option. So some of the things that we've done are a trumpet adapter. So a transradial amputee could hold her trumpet in her left hand and play with her right hand. Right underneath that one is a monkey bar specific prosthesis for someone with a partial hand amputation that does pretty much everything without a device except for monkey bars. So we designed that one specific. We started to design a new hand specifically for bike riding that allows kids to pop the hand on and off the handlebars, but it also has a ball and socket joint that helps them to steer more easily. We've done a really low profile carbon fiber foot plate for a case where there were no commercially available feet that fit underneath their residual limb. And in orthotics, we've even done some specialized hip abduction orthoses where we used the molded thermoplastic to make the thigh cuffs, but then 3D printed specific brackets to hold them in the hip abduction angle that we wanted.
So once their device is all ready, then we have our fitting appointment. So at this point, we're establishing the final trim lines, attaching our straps, checking our volume, make sure everything's fitting properly. And we check our static alignment, dynamic alignment, and all the time we're adjusting for comfort and function. There's a lot of patient and family education that goes on at the fitting appointment. And at this point, we're trying to get as much feedback from the family as possible so we know they're all good to leave with their devices. And then for follow-up, we don't always book follow-up, but if they're a new user, we try to see them back within the month just to kind of check in and see if everything's going okay. Regular users, typically we just follow up as needed, or they're being seen through other clinics and through therapy. If any issues do arise, we will book back as soon as possible, usually within a day or two. And I really can't stress enough that families just need to let us know if there's issues, because there's lots we can do to make sure things are working, but sometimes they don't call us and then we don't know that there's a problem.
So our program works on a self-funded fee-for-service program, and our primary funding agencies would be Manitoba Health, Assistive Devices Program for patients from Ontario, non-insured health benefits, the Vorum, the Children's Rehab Foundation, and then sometimes private insurance companies. In prosthetics, Manitoba Health and NIHB will typically cover 100% of a device that's for cosmetic purposes or for activities of daily living, but they don't cover anything for recreational activities or anything with especially expensive componentry like a myoelectric hand or a microprocessor knee. In those cases, some private insurance plans cover those types of unfunded devices, but we also access funding from the Vorum for most of our recreational devices, and the CRF helps us to fund more of the advanced componentry like myoelectric hands, microprocessor feet, running blades, things like that. So for P&O in Manitoba, we work off of a fee schedule that's a list of prosthetic and orthotic covered devices that is made by Manitoba Health. It's a really device-centric system that takes into account the cost of the materials and componentry, the cost of the clinical service time, and the cost of the technical labor. In order to access this funding schedule, you need to be a certified orthotist or prosthetist. So you need to be credentialed by OPC, which is our national association. And you also need to have facility representation by Manitoba Orthotics and Prosthetics Association, which is our provincial association. So the device list is negotiated between Manitoba Health and MOPA. And the program is currently under review because it's very outdated. So we're hoping to update it to account for new materials and new technology, to account for the fluctuating Canadian dollar and price of oil, to reflect the current evidence and research that's come available since it was created. We want to eliminate the abuse of loopholes that are typically taken advantage of by commercial providers. We want to update the program so that it's less device-centric and so that it focuses more on the overall treatment that we're providing. And we want to establish certified providers as the recognized providers of P&O care. So like I said, this is currently under review, and in times of election, it typically tends to slow everything down. But as we develop this new program, it might result in changes in the way that our devices are provided. Other provinces use a deductible system or some sort of copay, so something like that might be involved. But definitely, as we get more updates, we'll keep everybody informed on how funding is provided.
Okay, so for funding for orthotics, typically everything above the ankle is covered by Manitoba Health. With some exceptions, there's limited funding for off-the-shelf devices, but they will cover like semi-custom or custom to measure. So that's our carbon fiber AFOs and our soft spinal orthoses. We can get helmets covered for self-abuse or protective uses. Some are also funded by NIHB if we can get prior approval. For foot orthotics, typically they say they don't cover anything below the ankle. They will cover foot orthotics if there's a fracture, an amputation, or if the child is a previous AFO or SMO wearer, they will cover it as well. And then sometimes we're going through private insurance or other areas for funding as well. Orthopedic shoes, extra depth shoes, they're typically running at about $120 a pair. They're not covered by Manitoba Health, but there is about $30 rebate program that's available if you submit a prescription and your receipt to Manitoba Health. And Manitoba Health will cover modifications to shoes if they're done in conjunction with a brace. So how families are referred to us, typically we see them following an assessment and referral by physician, therapist, or at one of our RCC clinics. So we always have an orthotist on call for each of the 4 orthotic clinics: assistive technology, spina bifida, spasticity, and orthopedic. So we do our best to see everyone that's sent up from clinic. We understand a lot of these kids have very complex care, and we try to limit the number of visits for the family. And then we do have 2 prosthetic clinics, upper and lower extremity as well. We do see clients from Manitoba, Nunavut, Northwest Territories, and some of Ontario. Preferably they're being sent to us with a prescription from a physician or a completed referral form. So this is our referral form. We really appreciate therapists kind of filling this out if they're going to send someone up to us. Most important areas we're looking at to be filled out in this, obviously the area of body we're supposed to be assessing. The most important thing is kind of therapist view of the purpose of the device and treatment plan that they're working towards. So if we can have, some findings from your therapy assessment, strength, range, motion, gait, and then also your therapy goals, just so we know we're on the same page with you guys with what you're wanting to do with the brace. So whether we're trying to improve range of motion, prevent tripping, reduce pain, whatever your goal might be, it's good if we're on the same page. If you have a specific wear schedule in mind, whether it's just daytime, nighttime, at school, with shoes, without shoes, anything you have in mind, it'd be great if we knew that as well. And then we want to know the doctor involved in the treatment, just so we can send away for a prescription, and then therapist contact info so we can call you if we have any questions.
Where do you want us to send that?
Just to the form?
Yeah.
Yeah, just get sent to like Kim or Stephanie. Yeah. Tasket and Acuro.
Yeah.
Yeah.
Or Stephanie and then
Kim or Stephanie. Yeah. Thanks. So to access P&O Services, we do require a prescription eventually to get reimbursement for our devices. The prescription can be signed by physician's assistant, or nurse practitioner. Typically, it's best if this is a pretty generic prescription, like just AFO or spinal brace, although some of the doctors that we work pretty closely with here, they can be more specific because we kind of know what they're talking about. But all aspects of the treatment cycle from start to finish must be completed by the orthotist to access the funding for these devices. So if the client has a prescription, they can book directly with our admin. If there's no prescription, so if they're coming by therapist referral, if you're unsure whether they need orthotics, we'd really appreciate just a quick phone call or an email just to ask to see if we think bracing might be appropriate for these kids. We can always discuss, your progress notes, any photos or testing that you have available. And we can always book an assessment or consultation appointment. It's great if therapists can come to these appointments as well, just so we can kind of collaboratively talk with the families. And we can always get a prescription at a later date from the family physician. We do really appreciate the multidisciplinary approach at SCCY, so we're happy to come to your therapy appointments or to have therapists attend our assessment appointments, just so we can make sure everyone's on the same page and we're making things as easy as possible for the families. So it kind of brings up this group of our low-tone pronators. So we all know they're a pretty challenging group for both therapists and orthotists. Questions always come up: how early do we brace? What level of bracing is appropriate? Challenges: there's very little available literature that's good quality that's available for this area, and there's lots of differing conclusions about best practice. So a couple of years ago, we did have a SCCY hypotonia working group here, and we did come up with kind of a recommended procedure for seeing these kids. So the point of entry was always an assessment by physiotherapy. If they thought that bracing would be appropriate based on the outcome measures we selected, they would refer to orthotics. We would assess them, get a prescription from the doctor, give them the orthosis, follow up, and then physiotherapy would do any continuing follow-up. So again, if you're unsure whether or not to refer, please just contact one of the orthotists, phone or email, and we're happy to have a discussion with you.
So now I guess we're just going to touch on a couple of the special projects we've got going on in our department right now. The first one is an initiative to improve our workplace culture. We really want our department to be somewhere positive and supportive, where everyone's feeling that their work is really valuable and that there's a reason why they're coming to work every day, rather than other than just getting their paycheck. So we're currently working on a staff survey to help determine where the weaknesses in our workplace culture are and how we can improve them so that everyone's feeling really valued and invested in the things that they're doing.
We're also currently in the middle of a research project that's a partnership with MOPA and a UBC master's student. The research question is, with experienced P&O device users with chronic disability, how does certified P&O care impact their client satisfaction with their devices? So ISPO has recommended that patient satisfaction is a key component for outcome evaluation. It's not just about biomechanics and the hard numbers. So this study is using 2 patient-reported experience measures, and we're giving it to users who have been P&O users for at least 3 months. And we're hoping that the outcomes from this study will support the value of certified P&O providers and also support changes to funding and policy. One of the interesting things that's kind of come up as a part of it is all of the families participating in the study, we give them a service estimate of what their devices actually cost. And it's been very eye-opening to them, because a lot of them just kind of show up, they get their devices, and they really have no idea how much is really being covered for them. So I think it's good education for the families. And then the study is also hopefully going to document the current standards of P&O care and expose any strengths or weaknesses in our program and identify areas for quality improvement.
Another project we're working on is development of a novel pediatric wrist unit. One of the problems that we come across a lot with our upper limb amputees is that there isn't really a good commercially available wrist unit for the pediatric population. A lot of them are too large, too heavy, and difficult for children to operate. So this project started as a U of M engineering idea project to help make a more pediatric friendly wrist unit. And our team at RCC has been continuing to develop it. So the current design is a 3D printed wrist with a ball and socket joint that allows full pronation and supination, and then 45 degrees of wrist flexion, extension, radial, and ulnar deviation. And it has an internal planetary gear system that lets the child lock the wrist in the desired position. And it also allows for quick disconnect options. So if they had one recreation device that they use for multiple activities like playing trumpet, basketball, volleyball, they can just switch out all of their terminal devices really easily and independently. So we're currently just working on making it smaller and more durable.
Another project we worked on over the summer was a collaboration between P&O, MD&S, and working with Dr. Archer. So we developed a MRI compatible hip abduction device. So the goal was to be able to have this device in the MRI machine to help with diagnosis of developmental dysplasia of the hip. And this is going to prevent the use of anesthesia on these kids aged 1 through 5, because less than 1, they're able to be diagnosed through ultrasound, and greater than 5, they can typically sit still long enough for the MRI to happen. So this is the trial device that was fabricated. It's set in 30 degrees of hip and knee flexion. It's sanitary, very easy to wipe down. It's comfortable for kids to lay on, and there will be more sizes to come once we get some feedback on the initial trial device. Then kind of the last exciting project that we're working on, it's the development of this blended learning pilot project. So there's a big problem in Canada of a shortage of P&O professionals, and this definitely affects Manitoba. We have a really hard time, especially in Manitoba, attracting people to stay here. So we really need to increase the supply of professionals, and our 2 schools, BCIT and GBC, are not able to increase the number of seats at this point. So what the plan is there will be first intake in September 2020. So George Brown typically accepts 8 students every year, but they're going to increase that number to 10 students starting next year. And 2 students will actually be based in Winnipeg doing all of their studies here. So they're going to have a home base at HSC where they're going to attend lectures online in real time following the GBC schedule and curriculum. And then they're going to travel to all of the participating P&O facilities and complete their lab work and all their clinical work with patients. So it's all based on areas of expertise within Winnipeg. So RCC is participating as the pediatric experts in P&O care. So we'll be providing patient models, and we'll be acting as faculty to supervise and evaluate the students as they work through their practical and technical work. So we're very excited about that. And then hopefully, you know, once these students are done school, they'll be looking at staying in Winnipeg because they'll see how awesome it is. And hopefully we'll get some residents and kind of be able to increase our capacity a little bit. Thanks everybody for coming. Thanks to this wonderful group of people for making it fun to come to work every day. And any questions?
You mentioned the myometric hand, which I'm familiar with, but also the microprocessor knee, or?
Yeah, so the question is, what's a microprocessor knee? Most of the lower cost knees that we use, you can adjust kind of the flexion and extension resistance with hydraulics. So microprocessor knee actually has a microprocessor, an accelerometer, a gyroscope that monitors how fast the patient is walking in real time and can adjust the pneumatics so that it gives a really natural swing. Does that make sense?
Yeah.
Okay.
Super clear. Everyone knows what to do. Nothing from the chat. All right, thanks guys. Happy Monday, Tuesday. Oh, I'm sweating.